aphakia conquered, comparison of technique and outcome between two sutureless SFIOL techniques. I think we will start, sir. Start the session. You want to introduce yourself or something?
Hello, I am Dr. Tamojit Chatterjee, Assistant Professor, Department of Ophthalmology, Raiganj Government Medical College. Okay.
Myself, Dr. Hemlata, retina specialist from AIO, Bangalore Medical College.
I am Dr. Santosh Mahapatra, Chief Medical Officer, JP Rotary Eye Hospital, Cuttack, Odisha.
I told you. First paper.
I'd like to invite Dr. Chintan Desai. Is he here?
Paper 1009.
Not there. Okay. Next one, Professor Abdes Ali. Ali. Okay. Suprachoroidal Triamcinolone in Epiretinal surgery, safety and efficacy study.
Good afternoon, judges and colleagues. The topic of my presentation is suprachoroidal triamcinolone after ERM surgery, a safety and efficacy study. No financial disclosures. So ERM, as we know, is a fibrocellular proliferation in the macular area, and it leads to clinical symptoms because of anatomical and physiological changes in the macula. The prevalence is 5 to 12%, out of which 1/5 are bilateral, and the standard of care is pars plana vitrectomy with ERM peeling. Of late, various adjuvant treatment options are being tried because the macular edema takes some time to subside. So earlier, there are studies of using intravitreal triamcinolone, but the side effects of increased IOP are quite significant, and later on, steroid implants like Ozurdex are also tried. But they all have add on to the cost of the surgery and have significant side effects. So this suprachoroidal triamcinolone is new to the therapeutic armamentarium, and recent studies have shown that it leads to improved efficacy and lesser side effects. Now it has been used in various trials in retinal vein occlusion, pseudophakic CME, and diabetic macular edema, and even uveitis. Triamcinolone, as we know, is commercially available, but it requires a microneedle or catheter for injection, which is not commonly available commercially out of the trials. So we innovated and modified a 26-gauge needle along with sleeve of a 22-gauge cannula for safe and cost-effective delivery of suprachoroidal triamcinolone. So was the idea of this study to determine the efficacy and safety of triamcinolone suprachoroidal for regression of macular edema and improvement in visual acuity. So this was a prospective non-randomized non-randomized study which included 20 patients with idiopathic ERM, and all patients underwent pars plana vitrectomy with ERM peeling who had visual acuity worse than 612 and evidence of ERM on OCT. Patients with glaucoma, other retinal pathology and follow-up less than 6 months were excluded. So among these 20 patients, 8 eyes did not receive suprachoroidal triamcinolone, and 12 eyes in the suprachoroidal triamcinolone, 12 eyes received suprachoroidal triamcinolone, which was 4 mg in 0.1 ml. This is how the needle was made, that you just dock it from the other end of a IV cannula outer tube and then keep the tip exposed, and then this injection can be given. After vitrectomy, sometimes if you are at 25 or 30 intraocular pressure, then momentarily you can increase it to 60 so that the injection is easier. This is of late, this is the intra-op OCT picture of one procedure being done, wherein you can see the needle shadow and triamcinolone in the suprachoroidal space. The outcome variables were central retinal thickness, vision and intraocular pressure measured at pre-decided time points. And all these patients had a mean follow-up of 6 months, and most of them were pseudophakic. This is one of pre and post images of a patient with thick ERM, disorganized retinal architecture, but after the surgery at 6 months, this is the outcome. If you look at the vision changes, there was significant improvement in visual acuity at 3 and 6 months, which was statistically significant. And looking at CRT changes, the changes started earlier than improvement in the visual acuity at 1, 3 and 6 month follow-up. This is the pictorial representation of reduction in CMT. So CMT started reducing from 1 month onwards, whereas vision was significantly different at 3 months. If you look at the safety, redness, transient pain, and conjunctival hemorrhage were most common. There were no significant complications like endophthalmitis. And one concern always is there regarding intraocular pressure with the use of steroids. So we quite elaborately studied the intraocular pressure changes, and at 3 and 6 months it was near to the baseline. So to conclude, suprachoroidal triamcinolone led to an accelerated improvement in vision and reduction in CRT at 1, 3 and 6 months after surgery. And this offers a valuable alternative to expensive steroid implants. This technique is now being used for various indications across the world, and it led to significant improvement in these patients of epiretinal membrane after surgery. Thank you.
Thank you. I have one or two questions for you, sir. How do you quantify the improvement in vision is due to suprachoroidal triamcinolone? Because you are combining epiretinal membrane peeling along with triamcinolone.
Sir, in this actually, though it was non-randomized, but we had 8 patients who did not receive the suprachoroidal triamcinolone, and 12 patients had received suprachoroidal triamcinolone. So then we compared these two groups. Then we found that there was significant difference in reduction in macular edema after 1 month onwards. Till 1 month, there was no significant improvement. But after 1 month, the reduction in macular edema was much more in the triamcinolone group. Same goes for the vision, though at 1 month, till 1 month, there was no significant improvement in vision, but 3 and 6 months, they significantly had better vision than the group which had received, which had not received suprachoroidal triamcinolone. So that was the only factor which was different.
Do you use preservative free or?
Yes, sir. This is same Orocort which we get preservative free, which is for intraocular use. That only we use.
Then you could have used a smaller gauge needle because they have the particle size is much less instead of a 26 gauge needle.
Sir, with 26 gauge needle, I find that the flow and everything is absolutely fine, and I have not yet encountered any complications. Plus now with AIOC guided injections, we actually can localize where the drug is going. Though your idea is very valid that even smaller needles would be helpful.
Sir, my query is, the etiology for the ERM all are idiopathic or secondary ERM?
They are all idiopathic
All
ERM,
are
ma'am,
idiopathic.
where we could not find a reason.
Is there any chance of occurring of any suprachoroidal hemorrhage during injection?
Sir, out of my limited experience, maybe of 1.5 to 2 years now hundreds of these suprachoroidal injections have been given. I have not yet encountered, though theoretically, definitely there is a possibility, sir. So we should be careful. Thank you, sir.
Thank you, sir.
Now the next figure, interpret by Professor Dr. Pradeep Kumar.
So good afternoon, ladies and gentlemen. I'll be speaking on something which is actually opposite to what is being driven by the market about the importance of brolucizumab. Though I speak a lot about its efficacy in neovascular AMD and diabetic retinopathy, today I am going to speak about the non-superiority of brolucizumab when it comes to myopic CNVM. So we all know the established usage of brolucizumab. These indications have been validated. For novel applications like in myopic CNVM, it's extremely important to take an informed consent, and you should have an ethics committee clearance. Myopic CNVMs behave differently because they are usually type 2, they are above the RP. There is a debate between 3 loading dosage followed by PRN or going to PRN straight away. We went with the PRN codes in our study. The results, they have been titrated against various biomarkers like axial length, but nothing has till date proven that which particular biomarker will give us the prognosis of a particular myopic CNVM. So this was our trial where we wanted to compare the 2 drugs head on. It was a prospective observational study. Because why we do not label it as interventional, because for a RCT trial, a much larger sample size was required. So this was not a non-inferiority trial, but this was an observational study of limited number of patients. So we went ahead with standard parameters took 4 weekly readings for 52 weeks. So that's a 1 year follow-up for both subset of patient. I'll come to my patient. This was a 32-year-old lady presented with best-corrected visual acuity of 6.9, was complaining of metamorphopsia, post first brolucizumab, had drying of the macula, by 12 week, showed recurrence again, received second dose, and following that patient remained at 6.9 throughout the observation period. So this was a happy story. Now coming to another case where the right eye best corrected visual acuity was 660. This patient had earlier received ranibizumab and aflibercept. This time was randomized to the brolucizumab group, was non-responsive to the two drugs. Came to best corrected visual acuity of 6. The right eye required 4 injections in 12 weeks. And this patient very gradually improved and at 18 weeks achieved 618. Now another case where the brolucizumab was started de novo. This patient from 636 moved to 618 in 4 months and remained stable thereafter. Another case where we see that right eye is stable while left eye received 6 injections in 1 year and moved from 4/60 to 6/36. So by now you can see the trend of variable response with brolucizumab. It is not a panacea as has been documented with other diseases. This case required 3 injections just to maintain from 618 to 612 over a year. The 6th case, 5 injections over 9 months, and another case, 2 brolucizumab in 1 year, moving from 660 to 612. So we had 10 patients in brolucizumab group, 9 patients in ranibizumab group. When we looked at the change in best corrected visual acuity, in brolucizumab group, we moved from 0.62 to 0.37 with a change of 0.25 logMAR units. While in ranibizumab group, we moved from 0.73 to 0.46, 0.27 logMAR units. So there is not too much best corrected visual acuity change difference between the two subgroups. Same was the story with the central macular thickness. Now the key question why we did this study was to study whether there was a prolongation of inter-injection interval, which is so well talked about. We had to give 47 injections in the brolucizumab subgroup while 46 injections in the ranibizumab subgroup. So here comes the conclusion of our study that though brolucizumab can be used, it works just as well as ranibizumab. It does not act better. You cannot achieve longer inter-injection intervals, especially in cases of myopic CNVM. So the unpredictability of myopic CNVM remains. So this is the conclusion, and though this study gave out a negative outcome, it is extremely important in our scenario when in a country like ours, we are dealing with increasing healthcare costs and budget remains an extremely vital issue when treating patients. So we do not feel that brolucizumab should be indicated for myopic CNVM. Thank you so much.
Thank
Very
you.
good presentation, sir. Like in your case in series, did you had any reaction like as mentioned?
No, ma'am. Here we gave very few injections. We have a larger data of about 1,770 injections till date at our center. We have had 4 IOIs, but none in this series of myopic CNVM. No IOIs in this series. But yes, I like to bring out this point that once you are giving brolucizumab, one should carefully monitor the patient. IOIs do occur, and when they occur, you will require steroids to control the inflammation.
What is the average number of injections in each group?
In each group, 4.6.
And what was the criteria to give the injections at
Okay.
what interval?
Yeah, so the retreatment criteria for the shortage of time, I did not come out to that, was drop in visual acuity by 1 line, that is 0.10. If we saw any appearance of new SRF or IRF on OCT, and if the patient complained of increasing metamorphopsia. This was a subjective feature, but it is very vital that in most cases of myopic CNVM, when the disease activity recurs, the changes in OCT are picked up later rather than the symptoms of the patient. So it is mostly the symptoms of the patient which determine whether re-injection will be done or not.
Did you see any difference in the repeatability of between brolucizumab and?
Exactly, that was the point of doing this study, sir. We were expecting a longer inter-injection interval, but it did not occur. That is why we are recommending that one should not say that brolucizumab gives a longer inter-injection interval in myopic CNVM.
What is the usual interval?
Oh, the usual interval in neovascular AMD has been 14 weeks. In diabetic macular edema, yeah, I am talking about our cases. In neovascular AMD, we have had 14-week inter-injection interval. in diabetic macular edema, we have had a 9-week injection interval. So yes, this gives a fairly long injection
And
interval.
in myopic?
In myopic, no, sir. In myopic, you have to repeat just as well as ranibizumab.
Do you give the ranibizumab, that is a biosimilar or ordinary?
Sir, just for the sake of making comparison for the study to be acceptable for publication, we use Eccentrix. We use both Eccentrix as well as Razumab at our center. I do not find any difference between the two drugs, but since it has to be published, so we used Eccentrix alone.
Thank you.
Thank you.
Thank you, sir.
Okay. The next paper, amniotic membrane plaque to promote the retinal breaks, repair and recurrent macular hole closure. Speaker is present?
Not presented.
Not present. So next one, perfluorooctane octane as short-term tamponade
Pediatric art.
in pediatric rheumatogenic retinal detachment with PVR. Presenting author is Nawaz Sheikh. Dr.
Good afternoon, everyone. I'm Dr. Nawazish, and I'll be presenting our outcomes of perfluorooctane as a short-term tamponade in pediatric rheumatogenic retinal detachment with proliferative vitreoretinopathy. So as we know, pediatric rheumatogenic retinal detachments, the success rate is as low as 50% because despite complex vitreoretinal interventions and heroic maneuvers that we do, keeping this in mind, our purpose was to evaluate our experience and outcomes of short-term tamponade using perfluorooctane in pediatric rheumatogenic retinal detachments with proliferative vitreoretinopathy. So it was a retrospective analysis of children less than 12 years of age who underwent 25-gauge pars plana vitrectomy for pediatric RRD with PVR using perfluorooctane as a short-term intraocular tamponade by a single surgeon. Only those patients were included who had at least 3 months of follow-up after the removal of the perfluorooctane, and primary and secondary outcomes were assessed. So 9 eyes of 9 patients were included. The mean age of the patients was 8.66 years. The mean duration of tamponade of perfluorooctane was 10.44 days with a range of 7 to 12 days. Coming to the primary outcomes, at the end of 3 months, 7 out of 9 eyes had reattachment after primary surgery, whereas the 2 eyes that had a redetachment underwent an additional surgery, of which only 1 succeeded, making it ultimately only 8 out of 9 eyes having reattachment at 3 months. That is roughly 90%. The secondary outcomes was there was an improvement in the visual acuity and no sight-threatening complications of perfluorooctane in the form of corneal opacification or subretinal PFCL was seen in any of the patients. The first image is the intraoperative screenshot at the end of surgery with perfluorooctane fill. The second image is the intraoperative screenshot during the second surgery where the perfluorooctane was exchanged with silicone oil. We preferred silicone oil as we were expecting